Well, hello, I'm Jim Hoover, and welcome to my talk on health information management, dropping the N, and how we're moving towards a more informatics environment. I hope you enjoy the talk, and please contact me if you have any questions. My background is as a computer scientist. I have a master's degree from Johns Hopkins University, so I naturally tend to look more towards informatics rather than health information. Although I've been in the industry for about 10 years now, I found that health information management has slowly been shifting towards informatics. And as we see during the talk, there's a lot of related concepts between the two, and that's what we're going to explore today. A quick note on disclaimers. I've done my best to make an interesting presentation that's full of factual information about the HIM and HI industries, as we'll talk about. But please do your own research and make sure that you have the complete facts for any career direction that you might want to take following this presentation. So our agenda today, we're going to talk about the terms of informatics, health information management, and how they're related. We'll explore the evolution of HIM and healthcare IT and how they're intertwined. What current healthcare technologies impact the HIM or HI professions. And then we'll move into some future technologies from an informaticist perspective, my perspective, that you might find of interest and to get a sense for what health informaticists do. And lastly, we'll talk about some certifications and education that's available in industry, should this be of interest to you, and also possible HI, health informatics, career paths that one can transition from health information. HIMA has updated the language of our profession from health information management to just health information. Now, I can't pinpoint exactly when that happened, but I've noticed over the past year or so that everything is health information now, and it's moving towards more an analytical approach, which flows into informatics. I'm a very active volunteer in the California HIM Association. We call it CHIA. And even there, it's been a challenge for us to always drop the M. Lots of our documentation, websites, and presentations from professionals at our conference often include the M, should be saying HI. And we'll talk through what that means from what I could determine is a HIMA's perspective. Now, a HIMA is advising HI professionals, health information professionals, to, quote, upskill and take on a more analytical, proactive, and mission-critical role in shaping the governance, management, accessibility, and use of health information for consumers, clinicians, and provider organizations. That's a big statement. Well, what it really focused on, at least from my perspective, was the analytical piece. We're going to have to become more proficient with the analytical tools that are available to us and the data that surrounds health information to help all of our consumers of our data, patients, clinicians, administrators, public health, and so forth. So moving from HIM to HI really is driving us more towards an informatics sort of approach, also called HI, so it can be confusing. But what I found from a HIMA's perspective, their guidance is looking towards consumer health informatics, and we'll cover the different types of informatics shortly. And also please note, I'm not speaking for a HIMA, I'm just reporting what I've been able to discern so far. So there are 5 key points in the HIMA article on upskilling our HIM resources, our staff. They really focus on the analytical skill portion. But if you dig a little bit deeper, data management is also a critical function. Safekeeping the data, the provenance of the data, that's the who, what, where, when data was added to the system. And also, really important, keeping the data bias free. That means updating all the fields possible for the patients, the clinical records, in the financial information and the SDOH. That also means validating our data, and it also means testing for biases wherever possible. I spent a whole hour on this topic and we can't get to it today, but I want you to remember that as a key point, keeping the data bias free. Thirdly, it seems that AHIMA is really expanding our HIM role into the consumerization of healthcare. That is, patients will have access to their medical information from many sources, clinicians, portals, and even their cell phones. And as a result, they're going to have more trouble accessing the data. They're going to have more questions about the data as they read their medical record more closely. And that's going to put more of a burden, more a requirement on HIM to be acquainted with all the tools and understand what the patient's needs are and where they're getting the information from. AHIMA in the same article is also looking for more assistance from us from a grassroots advocacy perspective. We're not going to touch on that today at all. And lastly, AHIMA is pointing out that our HIM staff is going to need to support patients more closely simply because of that direct access they're going to have to our medical records. There's going to be lots of amendments to the records, for example, and amendments to the amendments, as we're seeing. Before we compare health informatics and health information professions, let's start with some vocabulary. These definitions I've provided are from the Oxford English Dictionary. There are two words and concepts that are familiar. Informatics is the science of processing data, and it's related to information science. Whereas computational is more related to using computers. For example, much of the work I do, I consider it computational healthcare because it involves algorithms and writing software to solve healthcare problems. Informatics is really more on the analysis side of the house. They really are similar words, so I think you should be familiar with them as we're comparing health information profession with health informatics. Healthcare IT does have a history of using computerized from its early days, which is a really, really dated term, I know. But according to the Webster Merriam Dictionary, this term was first used in 1957, really at the dawn of using computers in business. And many words that use computerized as the base are really dated. Computerized physician order entry, CPOE, for example, is one of those words. Well, computational is one of my favorite ways to describe healthcare, the work that we do, and it's used quite a bit in a lot of different areas. Computational photography is why our phones take such good pictures. Computational biology, computational linguistics, another area where I've worked in the past, computational vision, and medicine are all disciplines that use the computer in some way, shape, or form to improve the subject of which it's operating on. And that's why I tend to favor computational healthcare as the term of choice. Computational healthcare is the software side of the industry, and that's a multidiscipline intersection of big data, artificial intelligence, and patient clinical data. When we think of big data, we often consider the 5 V's of big data: velocity, volume, variety, veracity, and value. And these help us define what big data is and really how to manage it. AI, artificial intelligence, is also part of computational healthcare, and that's a set of computer science and math techniques to help predict outcomes or classify data. And they can help us improve testing diagnostics, for example, predicting disease earlier, and as we'll talk about in ChatGPT-3 later, a whole variety of areas are interesting. And computational healthcare relies on patient clinical data to do its job. And that's where our health information professionals come into play, managing, curating, and perfecting that data. It's clinical data entered into the EHR. It's lab work that gets integrated into the EHR and has to be associated with the right patient. Physiological data, family history, and so forth, and even patient-generated data from their Fitbits, iPhones, and other wearables that may become part of the longitudinal patient record. We don't necessarily own that data as HIM professionals. Understanding how it fits in, it's going to be part of our new analytical mindsets So I'm going to use AMIA's description of informatics. That's the American Medical Informatics Association. And they have a really good definition that I think is useful for the discussion today. It applies both the computer science and information science to healthcare domain. And that starts to really feel more like what we do in terms of managing healthcare data and health information management. Informatics is used a lot in medical research, public health, patient care, of course, consumerization of health information, and so forth. All of that is in the informatics framework. And some of this is where AHIMA is really pushing our industry to evolve towards. AMIA emphasizes this multidisciplinary approach in the informatics field. And they focus on really the health information technologies, HIT, to deliver the science to professionals in the space. It's at that intersection of information science, social sciences, and healthcare. Informatics really has grown exponentially over the past 35 years. The term medical informatics goes back almost 50 years, half a century. When Terry Collin coined that term, he was really focused just on patient data, and Terry's philosophy was to process it, make it more information rather than just data, and then we can take some action on it. We're looking to create value from the data through our analysis, through our processing, and when we have success with it, we're going to improve the quality of the patient care because we have more insights into the patient, into their disease state, into the treatment plans, and so forth. And as health information management professionals, the tools that we use to process this data are going to be the real keys that we can use to deliver the value to the clinicians and to the patients and to our administrators. There's a few more related terms to informatics I think are useful to define. Health information technology we're all familiar with already. That's the software and the techniques we use in our day-to-day jobs in health information management. And of course, HIM, we all understand what that is, and it's evolved tremendously over the past half a century. Digital health has become this new catch-all phrase for everything. It's the new computerized word, but it's everything related to healthcare on a computing platform, including mobile, the cloud, and so forth. The digital front door is something that we hear quite a bit now. But what I found interesting was that the American Medical Association has introduced a new area of study for the emerging medical doctors. And it's called Health System Sciences. It's the third branch of medical education for medical students now, in addition to basic and clinical sciences. But to be clear, health informatics as a profession is different from health information management. It's just that AHIMA's drive towards analytics, it's making some of us in industry understand that the overlap between information management and informatics is starting to get bigger, that overlap. Now, health information management is more focused on the managing and protecting of all things medical record related. Clinical data, coding data, billing, all patient-centric. And informatics really has a little bit bigger charter, looking at data from all sources like public health, the aggregation of data, and so forth, pharmaceutical studies, biological studies, and so forth, in addition to the health information. There's different ways to get into the career paths as well. Typically with health information management, one can start really at the front door, just registering patients, or being a medical records clerk, being a release of information, and so forth, with entry-level jobs as starters and work their way up without even a degree. Whereas with informatics, a bachelor's degree is often required because of the science base of it. And often in both health information management and informatics, professionals can get advanced degrees, Masters of Healthcare Administration. That's what I teach, and informatics masters as well. And informaticists can even get PhDs. So either direction, you can get graduate degrees and terminal degrees depending on what you want to do. Health informatics itself is very broad and has many subfields. All of the subfields are focused on creating health information and knowledge from the data, just like Terry did 50 years ago. The specific fields include biomedical informatics, clinical research informatics, clinical informatics, consumer health informatics, we've talked about quite a bit, and public health informatics. And we're all familiar of the COVID maps and other information, the statistics coming out. All of that came from health informaticists that worked in partnership with health information management professionals to bring the data together to synthesize information and create charts and other things to help understand the spread of the disease. Biomedical informatics is a very scientific discipline. It's about new healthcare knowledge published for the use by clinicians, patients, and researchers to understand the basic building blocks of life and health. It's an applied informatics field at the cellular and molecular biology level, such as the study of genomics, the structure, function, and mapping of genomes. But the field helps explore medical data, to identify clinical insights, and to help treat known diseases and uncover new diseases. Biomedical informatics creates new lines of scientific inquiry. Clinical research informatics, often called CRI, is a diverse area that investigates the safety and effectiveness of drugs, medical devices, and treatments. These informaticists produce evidence-based medical conclusions with their tools and techniques that really help improve the quality of care for patients and devise new treatments, etc. It's focused on a data-driven discovery process. Clinical informatics is directly related to patient medical care. Many areas of specialization are under clinical informatics, for example, nursing, pathology, pharmaceutical, pediatrics, nutritional, and so forth. And all of them within their specialties are focused on the care of the patient. Health information management and AHIMA's push for us to be more analytical drives us more towards consumer health informatics, in that our interaction with patients and sharing the data, helping them understand the data and how to get access to it, is a key area of this discipline. And informaticists play a major role in producing content, communicating that content, and sharing that health information to consumers through a variety of modalities: websites, cell phones, text, posters, so forth. In this age of self-care, for example, informed decision-making by patients is something that clinicians really value to drive healthy behaviors and a reasonable information exchange between the patient and professionals. So this is a really important area to improve patient outcomes as well. And finally, public health informatics. And the areas of focus include things like health surveillance. How do we acquire data to look at the bigger picture? And then educating the public on what are our risks or problems during the current times. Public health informatics is also useful to help predict outbreaks of certain diseases. It's all about the systemic capture and analysis of multidimensional healthcare data. So now we're finally at the topic at hand, the evolution of HIM and healthcare IT into health information. One thing we can be sure of, the only thing that is the same is change. We always change. Record librarians was what we used to call health information professionals way back in the early days. And this was a term that was coined by the American Medical Administration, and it was mostly female librarians, pre-EHR days. But as our industry has changed, the underlying technology, our professional designations have also changed, and you could look at the history page on the AHIMA site to get a good sense for that. It's very interesting. And as our industry has matured, our data sources have changed dramatically. EHRs, patient-generated health data, payers and government information, academic institutions, researched. I know I missed more than a few, but you get the idea. Each data source has its own characteristics and its own pre-processing requirements, its own provenance, etc., and its own biases. Part of becoming more analytical is understanding how to normalize the data for our use, to try to remove the biases wherever they exist or identify them, and make sure the data is suitable for consumption by our clinicians, our EHRs, and lastly, our patients. The core data, and that's where we really have the most ownership, is in the EHRs. We're all familiar with the components of the EHRs, but each one has a specific data type that ultimately we have some involvement with. Computerized physician order entry, for example, where the clinical notes are starting to get into the data. And of course, the billing information, our revenue cycle data that comes from our coding of the clinical notes and so forth, very, very important for the health of the organization. And in the early days, these were standalone systems that were brought together in EHRs. Same thing for registration that holds the patient demographic data. EHRs have become like giant software systems now from the building blocks of all this functionality. As more and more features have been added, these EHR systems have become monolithic in design, one big piece of software. But it's from those building blocks that the individual data comes from that we have to manage as information professionals. And as informaticists, we have to analyze. With modern EHRs now, there's even more components that we should be aware of that generate data. Patient portals, security information, who's coming in trying to access the data and why. Record request could be electronic now, the analytical tools we use to access it. EMPIs are systems we connect to and integrate and match patients against two different systems. Whole different area of health information management that we're all familiar with. Another interesting area of convergence of health information management with informatics is in the technology that is being applied to healthcare. Mobile health, wearables, cloud technology, interoperability, and AI. All of these have something to do with the intersection of these two professions. Data, data quality, patient access to data, compliance with laws, and uncharted areas such as AI. Artificial intelligence is a topic that is widely discussed in healthcare, and we've had it for a long time in one way or another. Natural language processing is one of the older areas of healthcare use of AI. And from the information management perspective and informatics perspective, it's about processing unstructured data, for example, clinical notes, and using natural language processing or NLP techniques to recognize words and sentences and phrases, subjects and objects and sentences, and so forth to help us get some understanding from what was typed or input. And with the emergence of social media, sentiment analysis has also become something that's quite popular. For example, we could apply it to understand a clinician's feelings towards a patient, which helps us root out some potential sources of bias. NLP also helps us classify text and also helps us model what was being discussed in the text. And for most of our purposes, it's usually for billing, revenue cycle. Clinical documentation improvement, CDI, is a really strong use case for natural language processing. Analyzing the clinical notes to understand what the patient issues were and helping to generate claims. Another example use case is the hierarchical conditional categories, HCCs, and the risk adjustment factors that go with. Looking for language in and around certain terms that will help justify certain risk scores for the patients. Expert systems are probably one of the earliest uses of AI in healthcare, and it's also one of the more straightforward strategies too. It's a dated concept, but it's still really very much in use today around clinical decision support systems, for example. Essentially what these expert systems do are try to codify the knowledge of an expert, like a physician, and make that information available for others who might not be as knowledgeable in a certain subject area, such as clinical specialty, for example. Clinical decision support systems use something called the Arden syntax to encode that knowledge, make that knowledge data that the expert system operates on and gives to users of the system, and helps the systems make recommendations for the patient's care. This is an esoteric area, it's a niche area, but those health information management professionals that have an interest in the clinical data side of the house, the treatment plans, might find some interest in becoming an ardent syntax expert and helping to build or modify or maintain these expert systems. Everyone's talking about machine learning now, and it has become the most common use of AI all across all industries. It's used for decision-making, classifications, prediction, and clustering. For example, it helps us differentiate between tumors and normal tissue. It helps us predict and treat diseases and gives diagnostic support to clinicians trying to make decisions about patient care. And it can be used to group data together, clustering information, such as medical records that belong to the same patient. So let's tie all these issues to AI algorithms. But remember, because we are custodians of the data, the algorithms are also only as good as the data we give it. That's why our jobs as health information professionals is so important. I talked about biases in data earlier, and this is a clear example where data that goes into a machine learning system directly impacts the recommendations or classifications that come out of it. Biased data in, biased results out. How machine learning works is that there are weighted connections between what we're calling neurons in our model that try to emulate what's going on in the brain. The connection between these neurons is what is considered the learning of the systems. For example, if we were to train a machine learning engine to recognize duplicate patient records, we might ask the fundamental question, do two patient records match? And to do this, we would supply training data to the network to learn from before we could use it as a predictive tool. And like the human brain, the interconnectivity between these neurons strengthens as it learns. And the weights between the neurons is where the biases are captured if it's in the data. The neural networks learn by bringing more data or unlearn, depending on what the training data we give it is. And we ultimately train a model to say it's a match or no match for a particular patient. And I've talked about biases quite a bit. And this is where I first noticed bias in healthcare IT data. And it was in the records that our HIM department selected as those that considered matches were predominantly based on date of birth being exact. We had very few examples where there was variation in the date of birth. So what that tells us is there's a strong inclination to assume dates of birth are correct over other fields. And that's a false assumption because there's nothing sacrosanct about a date of birth that it's immune from typing errors or other mistakes. But if we're not aware of that bias, using a machine learning engine for patient matching means we're going to have a lot of false negatives, records we do not catch as matches when there are errors in the dates of birth. Another area where machine learning has a lot of applicability, and there's a lot of data and a lot of places where things can go wrong in data, is in readmissions. It's a newer use of machine learning, but it's very, very powerful. Readmissions are quite costly to providers. The cost of care might not be reimbursed. Future reimbursement rates might be lowered for all patients if readmissions are too high. And our patients might incur a lot of additional risk and illness if they need to be readmitted for the same illness. So data is our big challenge here. What values do we input? How do we normalize those values? And ultimately, what training data do we give it to help us predict readmission risk or not? One of our big lessons learned in industry for readmission is that it's best to focus on data cohorts of similar patients. Patients with the same illness, for example. That'll give us the most accurate predictions of readmission risk. Age and illness, for example, for pediatric models are important, but age for adult models is not as important. So knowing what data to include and when to include it is a critical function that HIM professionals can participate and help guide. Same thing is true for race. It's generally understood that race is not a good predictor for disease state, and we should not use it as input to our models. We should use it on the back end to look for biases against certain races, but not as an input for disease state analysis. Generative AI is the newest approach that is catching the business world by storm. It seems like everybody's talking about ChatGPT 3 and 4 and all the things it can do and all the related businesses that are associated or competitive with OpenAI's ChatGPT. Google's Bard, for example, about these models is they're predictive. They don't understand the data at all. They only regurgitate the data in a manner that has been said before, based on if I said these 3 words, or if these 3 words were written before and after this blank word, what would that word be? That's why it's called generative. Very sophisticated in its prediction of what the words should be. That's why the output sounds so plausible. The systems are called large language models because they operate on huge amounts of data. Most of that data, this is going to scare you, comes from the internet. So the knowledge that is passed on from these generative AI systems is just whatever anyone wrote on the internet. So it has a huge sense of inherent bias built in, for example, that these companies try to weed out and put guardrails around the output to make sure that unsavory things are not said by their models. So I'll give you an example of how these generative AI systems are trained. And I'll start by asking a question. Did any of you play Mad Libs when you were a kid? You know, the teacher would ask for words. The students don't see the sheet until the end. They just give the teacher's words as they would ask for. Give me an adverb, give me an adjective, give me a noun. And then the teacher would then read the story back to the students with the substituted words. And it would usually be pretty funny, like moms may not eat like superheroes, but they have amazing super noses. In the same way, the systems train themselves by randomly guessing which words would fit into the holes in the text. And it trains itself on about 15% of the material and then tries to fill them in with words that are appropriate. The text that it trains on comes from all sorts of materials: literature, academic papers, websites, blogs, user comments on videos on YouTube, Twitter, software. It actually trains itself on software, so it can predict what words go in writing a software program. So these generative AI systems actually can write software. There's also generative AI for medical usage as well, and it's not very good yet at all. One of which is called BERT, not that BERT from Sesame Street, but it's an open source AI model that with natural language queries will try to give an answer about a medical condition. Now unfortunately, this BERT system was found not to be terribly good when it was tested for those that were seeking help with suicide prevention. And in fact, one of the recommendations from BERT was for the patient to go kill themselves. So you can see there's a lot of work to be done, and also understand that the information given is in no way understood by the AI system. So before we go any further, I know you're probably saying, why? What are you telling me all this for? Do I really need to know all this as my job changes from management to an analytical function? Well, the answer is no. I want you to be aware of these tools and the techniques because they are part of the job, because they will be part of the landscape as our career paths do become more technical. None of us are going to write these AI systems, but we will all use them. And some of us will help curate the data that's used to train them later. Having this foundational understanding is critical as our HIM professions become more HI. Generative AI is great, but as health information management professionals and informaticists, we always have to be on the lookout for bad data. I mentioned that these large language models collect terabytes and terabytes of data to do their processing, and a lot of that data has racist and hateful speech in it. A lot of other data just has wrong information. You ever hear the joke about, oh, I read it on the internet, must be true? That is kind of the case here, that false information and racist information is not something we want our AI systems given as output, especially in medical care. Another challenge or problem with these systems is that they are very costly to build. And there's a worry that some healthcare systems and businesses that have lesser means might not be able to use these advanced tools in the pursuit of their business objectives, and therefore fall behind the bigger and more wealthy enterprises. And the last thing of note that is interesting is these language models use an immense amount of energy to create the AI engine, the neural network that is then used to give the answers. So we are extracting a huge environmental cost in creating these big models. An interesting advanced topic in technology that's not spoken about much is federated learning. And this is one of the ways that smaller organizations can combat the challenge of not being able to afford building a large model. And that is to say, a lot of organizations come together to share their data to train a shared AI system that is then used by everyone who supplied the data. This is really distributed computing in a pure form, similar to crowdsourcing. And in fact, we've all used federated learning in one way or another on our phones. The predictive typing that happens when we're trying to do a text message or send an email, that predictive model that guesses which word we might input next came from federated learning. All of the cell phones in a particular network were used to train a vendor's software that is then used back on those phones to help them get their messages out. I did find an interesting paper when I was doing some research on this topic, slide 50, that describes federated learning very well on nature.com, and I've got a reference to it at the end. It talks about digital health might be limited in growth because of the silos that we build naturally in healthcare and the reluctance to share information due to HIPAA concerns. Now we overcome that for research when we anonymize patients, so that might be the answer, but it is a possible roadblock for federated learning. On the theme of data, health informaticists and health information management professionals have to manage demographic data. That information is used for billing, for clinical trials, finding the right patient and registration, and so forth. But yet, it's a very bad source of data. Lots and lots and lots of errors. So one of the future technologies that we need to look at as health information management professionals, looking at analytical solutions, becoming more analytical in our jobs, is how do we work with bad data? It's always going to exist. Well, what kind of techniques, technologies, solutions are available or will become available that can help us work within the confines of the data quality that we need? And to that end, I'll give you an example about patient search. Why is search so problematic? Did you ever notice when you're typing that you only type a little bit because you're afraid if you type too much, you won't find what you're looking for because there might be an error in what you type or error in what you're searching? That's the current state of search in almost every system, but we're going to focus on EHRs today. EHR searches do have a problem because they miss 30 to 90% of the duplicate errors in the systems. That is to say, we can't always find all the patient records when we're searching for a patient. And it's simply because it's using older technology from the 60s, 70s, and 80s. Failure to find the right patient records is what creates these MPI errors, duplicates, and overlays that give us a lot of problems and cost a lot of money to remediate. I asked myself when I was speaking at the California HIM Association conference many years back, what if we could find patients as easily as we find records on Google? If I search for a 60, 70-year-old song and I misspell both the first and the last name of the singer, I can still find the video I'm looking for out of 1.9 billion web pages instantaneously. But yet, if I make the same mistakes in the EHR, I won't find the patient with the same name. That's a problem. So how can it be that I can find an old song in seconds, yet I can't find a patient record when a patient's right in front of me and I'm only looking at 100,000, a million, 5 million records? That's a surprising difference in capability. And the truth be told, EHR searches should be easier to do because we have a smaller domain and we have a lot less records. And we know what we're looking for very specifically: first name, last name, dates of birth. But yet, EHR searches do not work as well as Google. Let's connect the dots. Medical records are full of errors, we all agree. Internet search works really well with data that has lots of errors. What technology should we look at to use for medical record search? Well, internet search technology, of course. Could internet technology really find Elvia Presley when we met Elvis Presley? And could an EHR search do the same with something as badly misspelled? Well, this goes back to data quality again. And from what I've seen, the low data quality in EHRs create duplicate records because we can't find the patients. That poor data quality and the old technology conspire against us locating the patient records. Even if EHR searches worked perfectly, we would still have problems because we have errors in our MPIs. In addition, as we think about health information and being more analytical, we have to understand the type of data that we're using as well. For example, many patients do not have English names, and non-English names often have different name parts that are harder to fit in our North American idea of first, middle, last name. And America is this great melting pot with names all over the world. Further, the languages have different scripts, that is, different alphabets, that then have to be translated to our English alphabet, the Latin alphabet, that often also has mistakes in spelling and pronunciation and so forth. All of these things work against us trying to find patients by their name. This is an analytical HIM problem that we should be solving. And this is what a HEMA means by becoming more analytical in our career paths. Let me give you an example of a possible collections of misspellings that no EHR would be able to find. Spellings in the first name, last name, flipping the first and last name, misspellings in the street address, the wrong street address, errors in the telephone number, the social security number, even the city. All of these things would make it impossible for us to find the record, anti-glue-benit, and locate the real patient, Janet Monahan. Properly set up search that uses internet-like technologies, has fault tolerance built in, can find those kind of records. And this is how we use our analytical minds and HIM to solve vexing problems in our industry. And my last comment on search is that we're looking at problems from a different perspective. And this is how we use our analytical minds. Instead of looking at text search as text, we convert it to a mathematical problem and look at it as something different. And ultimately, we can find a better solution to a really vexing problem in healthcare. So moving our job from custodians of data to doing analytics on data, we'll start to create insights like this to improve our systems. No one expects an HIM professional to become analytical overnight. So to that end, just like we have certifications for coding and other disciplines, we also have certifications for data analytics. You can get certified as an informaticist from AMIA's website. They have an ACHIP certification. You can get certified from a HEMA to become a Certified Health Data Analyst, CHDA. That will help acquire knowledge to become more analytical. There's also certifications from academic institutions. And there's degrees, master's degrees and PhDs in health informatics and related disciplines that you can also go after to upskill, as a HEMA is asking us to do. I want to touch briefly on the demand for the job market for those with analytical skills in healthcare. With the continued advancement of IT systems that are getting more sophisticated in healthcare, and ONC and CMS pushing forward with interoperability, the health delivery services models are changing. All of this means that we have to become more technically adept. Our HIM profession is really moving more towards informatics, and the data from all different sources is just making the job even more technical, requiring more analytical skills. So AHIMA has it right. HIM do need to become more HI oriented. Health informatics is really what they're saying in a way that's focused more toward consumer health. So let's consider jobs that are in that area. And as you might expect, there's a wide variety of places to work. In academics, vendors and technical sales and tech delivery, providers where most of us work now, payers. Payers use a lot of analytical resources to figure out how to be profitable yet still cover claims. Consulting and software vendors, federal government, and even fellowships are available for those that have an interest in informatics to get into the field. When I did research for this presentation many months ago, was to just go on LinkedIn and pull snippets from job postings that had analytics as part of the job in healthcare. Mostly from informatics, but not all. And you can get a sense. It's everything from design of EHRs and doing analysis of clinical data, building data warehouses and business intelligence, etc. All of these are tasks that analytical HI people would do. And then I looked at the skill inventory for most of these positions, and it had a wide variety of requests. Everything from deep technical work to all the way up to high-level managerial positions. The opportunities are, if you want to become more analytical as an HI professional, you could even get into the technical side of the house. To look at this from another dimension, people could remain employees, they could become consultants, they could start their own businesses. There's positions all over the job boards for those with analytical skills with health information backgrounds. So it's a very wide career path the more analytical you get. What I found the salaries were, for informaticists in particular, they range from 80s to 120K for decent level jobs, entry level to mid, more than I believe what a lot of HIM professionals make. So there's a good incentive to possibly become more analytical because the jobs that use those more technical skills do seem to pay more. And if you don't know this already, LinkedIn is one of the best sources for professional development. You can turn on alerts for job postings and constantly see what's being added to the LinkedIn job database to stay abreast of what skills and positions are opening in analytical fields in HI or any other field. And of course, you can connect with everybody. Feel free to connect with me. That's how you build up your knowledge base, by connecting to those that know something that you also might want to learn. And I'm going to close it out by suggesting there's many resources available for you to learn more about analytics if what AHIMA is asking you to do is of interest, to expand your current skill set, upskill, and apply more analytical skills to the traditional HIM job. I've listed some resources here to start with and mentioned some journals that you can Google and start to follow, but it's a good path to start down. I'm including my contact information as well. I teach professionally, professor at Charter Oak State College in Connecticut in informatics and technology for both the healthcare administration master's degree and the master's in informatics. So I'm a good resource for you, or I can point you to others that might have some specific knowledge you're seeking to see what's out there and is coming over the horizon. If we are to follow what AHIMA is suggesting, then more HIM people will probably start to pursue this path. The information's out there, the opportunities are out there, the jobs are out there. It's just a matter of they great interest in you. With that said, I thank you for watching. It's been a long hour, lots of information, but I hope it's been informative. Connect with me on LinkedIn, send me an email, follow my YouTube pages where I publish videos, and stay in touch. Thanks for watching.